Let's get started. Good morning, everybody, and welcome to the Center for Global Health COVID-19 series, which is designed to support our colleagues in LMIC settings who are now preparing for the COVID-19 response. Today, we're going to focus mainly on how to support your healthcare workforce in terms of PPE. And we have two phenomenal speakers lined up today. So unlike our previous, we're going to split the session between three. So we're going to start off with Dr. Jason Farley. Jason Farley is a professor of nursing and infectious disease trained nurse epidemiologist, and is also the director of the RN PhD program at the Johns Hopkins School of Nursing, and has extensive experience working in South Africa, amongst other places, with populations with MDR-TB, and is a frontline witness to some of the OPD challenges that we're seeing abroad. Our second speaker is Lisa Maragakis. You may have seen her. She's been in the news quite a lot. She is an associate professor in infectious diseases and is the director for the Hospital Epidemiology, Infection and Control. She has from day one been spearheading the Johns Hopkins Hospital response to the COVID-19 pandemic and ensuring that we all get to remain safe. So she's going to talk about hospital preparedness and strategies that could be applied to your settings. And we know that this is a hot topic, and so we will leave plenty of room for questions. But without further ado, I'm going to pass over to Jason Farley.
Well, hello everyone. Good morning, good evening, wherever you are in the world. It's wonderful to have this opportunity to speak with you today. I'm going to begin sharing my screen here and sharing some slides with you. Getting those ready. Bhakti, you can see those okay on your end?
I can.
Fantastic. Okay, so everyone, we're going to be thinking right now about SARS-CoV-2 infection control in the outpatient setting. And as I titled it, the rational rationing of PPE, because everywhere in the world we're struggling with both the supply chain as well as how to use what we would normally use as a single-use device multiple times. And from my own work in tuberculosis, where we use N95s routinely, we've been reusing N95s and doing so safely in that environment for decades. But we need to now think about how we appropriately do so with a virus that's transmitted differently than the bacilli of tuberculosis. So I wanted to go and start at the most basic level and think about just infection control in general, because we not only have the patient who we're exposed to in the healthcare setting, we also have our visitors. And in many places around the world, we've limited a visitor policy. We have reduced the amount of individuals engaging with the healthcare system. So that's one strategic method of infection control: reduce the number of contacts we have as the health workforce. But we as the health workforce can also serve as a vector of infection for this virus. We've seen multiple outbreaks in which a closed hospital setting or a closed long-term care facility have had outbreaks of SARS-CoV-2 as a result of the health workforce engaging with the population. And we know that, and we've got clear evidence that asymptomatic transmission of this virus can occur. So let's think a little bit more specifically and what we can do in an outpatient environment. The most important thing that we can possibly do is recognize the symptoms of SARS-CoV-2. So we've all heard the mild symptoms, the most common symptoms of fever, cough, fatigue, which are very non-specific symptoms, particularly as the southern hemisphere of the world are moving into cold and flu season. As you're moving into winter, and as we're getting ready to move into summer, it overlaps quite dramatically, oftentimes with allergy season for the spring. We also know there's some key identifying features that are rising on our level of suspicion, including particularly the loss of taste or smell. Patients often experience a headache, aches and pains, the myalgias similar to influenza. Sore throat and diarrhea are typically less common. And in patients who get, more severe illness, we've defined COVID toe or COVID finger that has to do a lot with the inflammatory processes that occur as well as the coagulation issues that are ongoing. But importantly, we also need to recognize significant symptoms of that patients may present with, any significant difficulty or with breathing or shortness of breath, chest pain or pressure, or loss of speech or ability to move. Now, in low and middle income countries, you often deal with multiple diseases that can cause a myriad of these symptoms. You know, as the work that I do in tuberculosis, you see many of these overlap. We often think of cough, a dry cough lasting, potentially weeks on end, potentially fever, although it's less common, but patients experience weight loss and fatigue, productive sputum, but chest pain and pressure is another common hallmark of persons with tuberculosis. So I showed these two images here on this slide particularly because I want us to frame the way we're thinking about this and treat basically every patient right now across the world as if they are virally infected with SARS-CoV-2, even potentially asymptomatic, and even in that point can be transmitting the virus. So on the left image, you see a healthcare worker there who is wearing a surgical mask or a paper-based mask. It doesn't look like an N95. And she's providing hand sanitizer to the patient. She's squirting it. They're all positioned 6 feet apart, and they're outside. Now, this is what I would consider an extraordinary image of a great infection control response in this outpatient setting. On the image on the right, you see a gentleman who's being screened for his temperature to see if he might have fever. Remember, once fever has started, and you become symptomatic, you might have been transmitting for several days prior to that. So we can't rely on that. But if that's all you have at your disposal, and that's the first time you can screen, or you can't make multiple changes, then at least a fever screen is something that I would highly recommend. When we think about things that you can do, all those images you were just seeing are considered administrative controls. The types of administrative controls similar to what we would use in a tuberculosis. We think of symptom screening, cough etiquette, separation and fast tracking of patients who you think might have COVID away from other patients. Prompt diagnosis, screening and diagnosis, making sure the staff are aware how to spot those symptoms are really critical. And then, of course, patient education. Now, from the environmental perspective, we need as much natural ventilation as possible. Remember, the solution to pollution is dilution. And so really thinking about how we keep patients as much as possible queuing outside. Don't allow them to be in the environment as much as possible. Mechanical ventilation is really critical, and I don't mean the type in which we've got a patient on a mechanical ventilator. I mean how your HVAC, your HVAC system. And with the mechanical ventilation, is it HEPA filtered? Is it not HEPA filtered? Is an extremely important question. And many circumstances, many low and middle income settings don't have that type of HEPA filtration, maybe in a private or a tertiary hospital that Dr. Maragakis will talk about, but in our outpatient clinics, that's just not an option. So you want to make sure you're keeping your windows open, queuing patients outside, again, trying to limit the viral burden in your environment. And then, of course, personal protective equipment. Staff awareness on how to use it. We know that routine fit testing of N95s is not common. Even in drug-resistant tuberculosis settings, we don't routinely fit test our healthcare workers. We do more of a seal check, making sure that our glasses aren't, overly fogging, although that we can still see it in hot and humid environments. We want to make sure that people know how to use the respiratory protection. But in this circumstance, unlike TB, we're adding eye protection, wanting to make sure our eyes are covered because this virus can impact our mucous membranes. And most importantly, you have to work with your supply chain. Your PPE stockouts are being seen across the world, and it's really critical that we pay close attention to what is our supply chain and how do we appropriately ration that supply chain so that we can use and protect ourselves as healthcare workers as important as possible. So again, we talked about triaging patients. Any symptomatic patient needs to be cordoned off or triaged into a fast-track lane, moving them through the system as quickly as possible, preferably keeping them away from other patients. Keeping all of your patients in a paper-based mask if you have it. Putting everyone in that paper-based mask if they're at your healthcare system. Number one, reduces stigma of patients, oh, they may have COVID or oh, they may have tuberculosis. Just keep everyone in that paper mask while they're there. Even when they're outdoors waiting, if you can't control the distancing, a paper mask might be effective if you have enough supply. Again, separating those contacts, ensuring patients practice cough hygiene. Remember, coughing into the elbow, hopefully having a mask if they don't, giving them tissues and disposing of that correctly. Minimizing contact time. Again, fast tracking people with symptoms through the system, not giving them poor quality care. That's not the same as fast tracking them. But if you identify someone in that outpatient open air environment who has symptoms and they need to be seen, getting them screened, getting them evaluated, and moving them through the system, preferably with a patient visit that occurs completely outdoors, is the best way to go. Again, keeping people spaced at least 2 meters apart while in queues, like you saw in that image, and then consider as much, like I said, clinical opportunities as you can that are outside. Many settings have naturally ventilated waiting areas, queues outside designed for tuberculosis. Those remain really great, except one thing. We all know that every chair in that queue is taken. Patients are side by side, elbow to elbow, and they simply move down the queue in the line until the next person is called. That should not happen under the circumstances of SARS-CoV-2. We should spread those chairs out, and if people need to sit and because they can't stand, we need to have them spread at least 6 feet apart or 2 meters apart. And thinking about, again, that mechanical ventilation, it's really important to know how your air is flowing. We've had to do, and Dr. Maragakis can talk about this at Johns Hopkins, complete re-evaluations of the way the air flows in certain units in our hospital. That, again, HEPA filtration might not be available in many outpatient settings, but if it is available, that is a great thing to understand, working with your engineering team and your facilities team at your institution to know if it's there. And then finally, in certain TB units, we see a lot of ultraviolet germicidal irradiation. Many TB units that I work with in South Africa, for example, have now been converted into COVID-19 units because they have both HEPA filtration and at times ultraviolet germicidal irradiation. We know that certain waves of UV will kill viruses. They certainly kill tuberculosis, and in certain circumstances that might be a benefit as well. So when we think about the respiratory protection and control, we again need to focus on an entire respiratory protection program. Not only making sure your patients are aware of the respiratory hygiene and etiquette, but you must train your workforce on the appropriate use of the N95 and or other surgical type mask. Because remember, not all masks are created equally. And so here's a comparison between the surgical mask and the respirator. So again, putting as many patients as you can in that surgical mask helps to reduce viral burden in the environment. Putting the healthcare workers who are at low risk settings in that surgical mask is another great thing. And we should also use it as much as possible in waiting areas, consulting rooms, keeping the patient in that mask. The N95 are more your isolation wards, known COVID patients, making sure the casualty areas in the theater have access to N95s, and your screening tents in community clinics and outpatients. Community health workers who might be doing home visits or helping with your screen program as well should be in an N95 if available. If you don't have them, I put the image on the left-hand side of your screen of this healthcare worker wearing a paper mask covered with a face shield. Whether it's an N95 or a paper mask, you want to do your best to protect that from becoming contaminated with virus. And that's the purpose. It also protects your eyes from potential exposure. Here's a great slide about the importance of N95. And this is available at n95decon.org. So if you're looking for some details about the different types of N95s that are available and how they work, there's some great imagery out there for you. There's also some very important messaging about how to do fit testing when you don't have necessary equipment to do it, and how to do a seal check. There's also information about how you can decontaminate the mask. Importantly, if you have access to N95, it is important that we reuse those right now. We are needing to reuse them more than we normally would in a low and middle income setting, and make them stretch and last as long as we can. The images here that I've taken and from our TB hospitals in the past are basically showing you the perfect kind of storage, open air storage with a person, with a healthcare worker who knows exactly where their mask is in their storage bin, and they know how to use it. The masks are not folded, they are not bent. And we teach our healthcare workers that once those straps become loose and that seal becomes less tight, that's the time you have to change that mask out. Now, we're unfortunately right now having to tell healthcare workers stories about, waiting till it's soiled. Most importantly, Soilage is one thing that reduces the efficacy of the N95, clearly, but also the seal of that mask. How tight those straps remain around your face is extremely important. And I know personally from wearing an N95 all the time in our TB wards, after about 3 days of use of my N95, I'm getting, concerned about how tight those straps are and how much it creates a seal around my mask. So importantly, we need to think about how do we decontaminate and what could be done to decontaminate N95 masks. And there are 3 WHO recommended methods that are, quite frankly, cost prohibitive: humid heat, hydrogen peroxide vapor, and UVC radiation. So again, if you have access to these, you can potentially explore the ways of best doing it at your site. These are the 3 recommended. We do not recommend applying soap, bleach, any kind of specific kind of soapy water. We also know that when you store the mask, you can't store it in plastic. You have to store it in something breathable, either open air, like you were seeing in that image, or in a paper bag. Allow it to breathe so the moisture wicks away. Those are really extremely important kind of activities. We can talk more about this if there are questions, but basically most locations, and particularly low and middle income settings, don't have access to the features that would allow this to occur. Now, in terms of infection control at home, for your patients, ventilation, open windows, isolation of patient, ideally in their own bed, cough hygiene, refraining from close contact with family, and then maximizing airtime in the open environment. And if you have to receive visitors, they should receive them outside. So I just finish up here with a couple of images that are classic. You see a very crowded ward here with lots of visitors. Patient beds are clearly not 2 meters apart. We've got our nurse wearing our N95. And you see that the fans here that are designed to circulate the air in this circumstance are not on. So clearly what we'd want to do in this circumstance is unpack that ward, get it, patient beds farther apart, get our nurses in PPE that covers their eyes, get the visitors out of this location, turn on the circulating fans, and make sure all of our windows are open. Here you see a patient being nebulized at the bedside. We would not want to do this inside. You can see that tank of air right there is on wheels. You would want to get that patient out of that environment, outdoors, and if you have to nebulize them outside. Here you see a very crowded waiting room. This is in South Africa with a very, very, it's going into winter months right now. Right here on this image, you see this screen right here at the back of this queue in this waiting area. Really importantly, number one, we need to unpack this, have these patients wait outside, but right behind that screen is this box. It's the nebulizer box. This is where they would nebulize patients who have any need for nebulization, including sputum induction. Now, importantly, sputum is a great way, it's lots of virus in sputum, it's a great way of diagnosing, and gene expert machines that we use for tuberculosis can also be redeployed to use for in some cases, for the diagnosis of COVID-19. But we would never want today to be nebulizing patients in an outpatient clinic, particularly when on the other side of that wall, you have a major queue waiting. And we really have to think about how we're reorganizing our clinical structures and processes in those clinics to make sure patients' flow doesn't contribute to further transmission in our sites. And then finally, yesterday was the International Day of the Nurses Day. There have been so many voices of nurses throughout this that have been a voice of comfort, practice, and science, and many different circumstances, including the social media campaign, We Stayed at Work, so you stay at home for us. And we've seen that throughout the world. And so a big shout out to all our frontline healthcare workers, and particularly in recognition of our nurses during Nurses Week and the International Day of the Nurse yesterday. Thank you very much, and I appreciate your time.
Thank you, Jason. We're already getting some great questions for you, so stay ready. I'm going to hand over to Lisa Maragakis now to talk about the institution-based response for COVID-19. Give me 1 second to just share my screen. Okay, can everybody see that?
I see your desktop, but not the slides.
Oops. Okay, 1 second. I just bragged at how I knew how to do this. Okay, does that work?
Yes, thank you.
Perfect.
And thank you for the invitation to join you today. in this really unprecedented time. And I think Jason, so much of what he said applies to the inpatient setting as well. And so I'm going to refer back to a lot of his comments and just set it in the broader context of what we're all dealing with in terms of an emergency response to this unprecedented event, and then make some comments about the inpatient setting that correlate with what Jason has covered. Next slide, please. So we know that we are facing a pandemic, a worldwide threat from, next slide. Sorry, this has some animation in it. So from SARS-CoV-2 that has joined the family of coronaviruses and put us now in this worldwide pandemic situation. Next slide. And I think that we need to keep in mind as we face this giant threat that outbreak management is at the core of what we do in infectious diseases, in public health, in infection prevention. And so in the face of this urgent emergency, that we are responsible for taking every step that we can to prevent further spread while we care for the cases and protect our healthcare workers to bring the outbreak as rapidly under control as we can. And our own decisions really have life-saving consequences. While this is daunting and the scope of the threat and the number of patients are really overwhelming in many cases, I would urge us all just to remember that this is the basic pandemic response, is the basic outbreak response for which we have prepared and with which we're all familiar. And so in our attempts to deal with such a large calamity, we can go back to the basics and focus on proper case identification and enhancing the basic infection prevention practices that we know work. And unfortunately, this infectious disease right now, we do not have a vaccine. We do not have a proven therapy. And so this situation, like none other, really emphasizes the importance of going back to basics and relying upon all the things that we know work. Hand hygiene, environmental cleaning, and social distancing have become the backbone of our response. In addition, our role, of course, is training and supporting our colleagues to do all of these basic things, collecting data and communicating. Risk communication is an important function as we help our colleagues through this. And then, of course, we all know and have recognized that essential healthcare services must be maintained. So while we have an influx and a surge of patients who are affected by this infection, we are also providing life-saving medical care to people who are affected by things other than COVID-19. Next slide. And this is all embedded in the principles of emergency management. And so one thing I would urge everyone to do, if you have colleagues in your organization or in the Ministry of Health, in your local community who have expertise in emergency management, they are invaluable colleagues with whom you can partner as you respond to this pandemic and anticipate the next set of threats that may come. And it is a continual cycle of preparedness, response, recovery, and mitigation that we are all in right now. And so this is one step that we have taken at Johns Hopkins, and I would urge everyone to do, and that is to really form a multidisciplinary team and make sure that someone who is well trained in emergency management is at the table to help organize the response. Next slide. So as we create our preparedness plans, a surveillance system, of course, is always important. And this gets back to the idea of the basic skills of outbreak management. So having case definitions and some sort of screening and triage process. And Jason alluded to this in his remarks about the outpatient setting, but it's also very important in the inpatient setting, as you can imagine. So thinking about all of the portals of entry to the organization and putting systems in place so that patients can be rapidly identified who have any complaints that raise suspicion for COVID-19, and then thinking through the workflow so that those patients can be as quickly as possible isolated from the other patients who are seeking care for non-COVID related processes. And that triage process is very familiar in the emergency department, but of course we know that there are other portals of entry, referrals from the ambulatory setting and others. I would also pause to comment that collaboration between outpatient and inpatient areas can be very helpful in managing the volume of patients that are presenting to emergency care areas and inpatient locations so that effective outpatient management can really divert a large number of people from presenting to the inpatient setting and thereby prevent a crisis of a surge in the inpatient setting. And a lot of that can be done through effective communication and reassuring worried well and mildly ill individuals, providing them with the information that they need so that they don't need to come to the inpatient location. I have mentioned and will mention several times through the presentation the importance of reinforcing basic infection prevention practices and training our colleagues and supporting them as they are caring for these patients. And of course, coordination with health ministries and other public health authorities can be tremendously helpful. I've mentioned the importance of diverting and helping outpatients stay outpatients to keep the surge from hitting the inpatient setting, and public health authorities can be very helpful in this regard too, both through risk communication as well as public-private partnerships to address high-risk communities who are particularly vulnerable to transmission of the disease, such as the elderly, those with comorbid conditions, those living in crowded conditions or experiencing homelessness and other vulnerable conditions. And so partnering with the community is very important. Next slide, please. I have mentioned emergency management expertise as an important partnership with infectious disease and public health and inpatient physicians. And as part of that, I would urge everyone to consider, if you haven't yet, implementing an incident command structure. This gives some formal structure to the flow of information and communications roles and responsibilities. And it really helps your organization organize the response. There are so many willing individuals who have a lot of expertise and a lot of good ideas, and Incident Command can help bring all of those things together and make actionable goals and objectives and assign roles and responsibilities and help organize the response. So there are many resources for this if you don't have the expertise yourself, but I would encourage everyone to consider setting up an incident command structure. In a large organization like Johns Hopkins Medicine, we actually have hundreds of people participating in ours, both at the health system level and individual aspects of our inpatient and outpatient healthcare delivery system. Next slide. So this slide, I know it's a laundry list, but really I think that it is helpful to have a checklist like this. And the title here says for staff education, but it's more than staff education. It is for staff support, to support our colleagues and our institutions during the response to the pandemic. I've already talked about screening for illness amongst our patients and triaging them to different areas. This is also true that we need to have a way to screen our own employees for symptoms as well. And during this response, we have moved from a period where we could use epidemiology, risk factors, and symptoms to effectively screen into a time where there are so many cases in many communities around the world that it really shifts to a symptom-based screening. And this is true no less of healthcare workers who have their own possibility of being exposed in communities and coming to work potentially ill. So that is a very important aspect to have in place. I've mentioned the emergency management plan and procedures. Jason covered nicely the modes of transmission of this virus in particular, and just another word about that because it has a bearing on personal protective equipment. So the WHO recommendations are for droplet precautions with eye protection, and this is the type of protection that most facilities are utilizing when masks and eye protection are available in order to protect mucous membranes from the larger droplets that are expelled during coughs, sneezes, and even talking or singing or breathing. And we also know that aerosol generating procedures can sometimes, for respiratory viruses, create smaller droplet nuclei. And so there is a question for this virus about aerosol or airborne transmission, and thus the concern that when available, respirators should be worn for those aerosol generating procedures. And there's a lot of debate and research about which procedures actually cause these aerosols to remain aloft. So I won't cover all of that, but just to say that consideration needs to be given to guidelines for your organization based on the PPE availability and how to target that to the highest risk procedures and settings and patients. I can say within our organization, and I'm sure it's true in others, that when there is a infection that causes fear and anxiety there and a shortage of personal protective equipment, this can cause a lot of intense discussions, and prioritization is so important in this setting to direct those supplies to those who are at the highest risk. Jason covered nicely use and reuse of PPE. In addition to his comments, I would add that although there are those reports and fancy ways of reprocessing or disinfecting N95 respirators, I have not been overly enamored of that, just because I feel like we have clear guidance about extending the use of these devices that are usually not used as long as we are currently using them due to the supply chain challenges. But once an N95 respirator has been used for a period of time, as Jason alluded to, it becomes visibly soiled. And usually that is from our own skin oils and respiratory secretions on the inside of the respirator, rather than external contamination. If you have available a face shield, this can be a very effective way to protect the N95 respirator itself from contamination from the patient side, from splashes or sprays. But once that respirator loses structural integrity or is visibly soiled, it really does need to be replaced if possible. And then you see on the right side of the slide other aspects of the whole institution's response, including everything around cleaning and disinfection of the environment. Thankfully, this virus is easily killed by disinfectants that we use on a regular basis in healthcare settings. So nothing special needs to be done there, but again, the devil is in the details, and the implementation of thorough cleaning of environmental surfaces, disinfection, and some kind of quality assurance program to make sure that high-touch surfaces are being effectively disinfected is important. And similarly, waste management procedures and postmortem care, unfortunately, are primary considerations. Next slide. And next slide, please. So I wanted to say something about risk communication. I think it's incredibly important that we, as leaders of the public health response, keep this in mind. Many of you are likely already experts at this, but in this time of fear and anxiety amongst the community and our own colleagues in many cases, it's so important to remain calm, build a sense of trust, and use the best practices of getting out ahead of the information and the story, providing information, providing data in a transparent way, and really listening to people, understanding what their concerns, what they are concerned about, what are their questions, and being a trusted voice now is very, very important. Next slide. We can go to the next slide. I just wanted to talk, I know I want to leave time for questions, but I wanted to talk a minute about environmental controls, if you have such available, for the air handling to be adjusted in the inpatient setting to create negative pressure rooms and units. So I alluded earlier to aerosol generating procedures and the possibility of airborne droplets and under those conditions, droplet nuclei. And so when possible, for those procedures in particular, and for care of COVID-19 patients, if you are able, negative pressure or exhausting more air than is supplied to a room is an excellent way to protect the surrounding areas and the staff members who are working in those units. Ante Rooms are an additional help if you can construct these, or if you have these available. That's essentially an airlock that protects the patient care area or the procedure room where the aerosol generating procedures are being performed from the surrounding areas. And if these are available, appropriate signage and HEPA filtration, if it's available, are additional steps that you can take. We've already talked, I think, about the personal protective equipment that are shown here. Face shields, I think, have really become an important piece of our PPE as we try to extend the use of our masks and respirators. And then there is the issue of universal masking, which many countries and jurisdictions have implemented now. And trying to communicate the difference about wearing a mask, a cloth mask, to contain one's own secretions and protect others, and how that differs from what we do in healthcare in the inpatient setting of trying to wear fluid-resistant PPE to protect the healthcare worker from splashes and sprays. And then just a word about infection prevention support and guidance, as well as mental health support for employees. This is an incredibly stressful time for providers who are on the front lines and taking care of these patients. Many stressful and distressing events happening. And so it is, when possible, so helpful to have infection prevention expertise and or safety officers assigned to be present in these areas and support the staff, and people who also have experience in psychological first aid to be available for their mental health support. Next slide. I want to leave time for questions, so I will just go forward more. Well, I'll say a word about employee exposures. We all know that despite our best efforts, patients will slip through who are unrecognized to have COVID-19, then they are later diagnosed, and that does happen, and we can mitigate this by our PPE, by our universal masking, and then social distancing when possible, and the symptom screening that we've talked about. Very, very important that our employees not work ill, because that can become the nidus of spreading infection further. Next slide. Let's go to the next slide. I just wanted to say a word about response to disasters and pandemics. And this is a graph of sort of the emotional low or emotional high of a whole group of people as they respond to any type of disaster, no less a pandemic. And so the impact happens. There's a phase of rushing in as a group, heroically trying to respond, and kind of a honeymoon period where people are really feeling good, working together and trying to respond to the challenge and seeing the positive results of what they're doing. And then unfortunately, we need to keep in mind that there is a period after that where the community and the group does become stressed and fatigued. And I fear that many of us are in this phase now where the end is not yet in sight, and people are becoming somewhat disillusioned and discouraged. And so there are things that we can do, and that's the reason that we need to support each other, monitor for psychological distress, administer psychological first aid, and take time out of each day for some wellness activities, so that the healthcare personnel themselves don't become so discouraged that they don't come to work, or that they start suffering their own negative consequences. So with that, I'd like to stop and turn it back to questions.
Thank you so much. I now have a visitor to our talk. So the first question I have, which I'm going to ask Jason to address. One second, can you say hi? And then Mommy's going to ask a question. Jason, the question we had was on your differing guidelines to what is recommended by WHO. Do you want to address those for me?
Yeah, absolutely. So first, thank you, colleagues, for the question. The point of the comparison between the paper mask, surgical mask, and the N95 was not to make a recommendation one way or the other, because it's way too nuanced to get into all the specifics of where I think an N95 would be appropriate. I personally have been in our testing tents here at Hopkins. If I'm distant those 2 meters, I'm in no PPE. Once I'm in, the kind of the non-safe zone, the dirty zone, if you will, then PPE is required with an N95 and a face shield, and that's when we're screening patients. Where I hedge a little bit with the WHO, particularly in an outpatient talk, is that so much of the outpatient environment is the unknown. The casualty, the patient is walking in and we don't know exactly what the scenario is yet. Also in our screening and testing sites, I also hedge because as I've been doing those procedures myself with particularly the NP swabs, patients are coughing right in my face oftentimes and speaking and right there with me, inches away from them. So I count that as an aerosol, that testing as an aerosolizing generated procedure because I am so close in proximity. And that paper-based mask is just not, in my opinion, fully effective. So we put our healthcare workers in that testing scenario in an N95. But I firmly agree that this is a droplet organism. It is transmitted by aerosolizing, generating procedures, and that's why we need those N95s. I concur with Dr. Maragakis and her comments. And I don't go against the WHO. I just think that there are scenarios that are, place the healthcare worker in the best protective circumstance for them possible, and kind of pay attention to the epidemiology around you. And that's the recommendation I'm making. I think we veer off the WHO guidelines on several occasions at Hopkins where we are in close alignment, but not always perfectly aligned. I don't know if Lisa has thoughts on that as well.
Lisa?
Sure. Well, I'm reading through the chat questions, and there are lots of questions about masks versus N95s and some of the different products of varying qualities and counterfeit products that are on the market, and we are all dealing with these things now, and it's very unfortunate. But yes, I absolutely agree. With the recommendation for treating this organism primarily as a droplet spread. We have some data that suggests that cloth masks, I made the distinction earlier between cloth masks and PPE for patient care. So I just want to say that again. Cloth masks themselves are effective barriers for containing your own respiratory droplets and protecting others around you. So in social situations, in the common areas with your colleagues, one of the biggest risk factors we found for transmission amongst employees to each other is the break rooms, where there's often not a lot of room to eat or sit or take a break, and they're crowded in there and then removing their masks to eat and drink, and becoming a risk to each other. And we've had outbreaks amongst our employees in that aspect. So social distancing is an important piece of that, and trying to take turns in the break room or find outdoor areas or other places to take breaks is important. Leaving that distance between each other, you know, the 6 feet. The cloth masks add a barrier, as I said, that protects other people around you. What we really want in the healthcare setting is some degree of fluid resistance. So I saw some questions in the chat about filtration of regular masks. You know, masks are loosely fitting, and so whether it's a surgical mask or a procedural mask, the filtration coefficients are available when you look up product information, but it's really not terribly meaningful because air can flow around that mask. So really, again, that is just a barrier, and the fluid resistance of it is what's protecting you from splashes and sprays. And you can test that yourself by pouring a little bit of water on one and seeing if it pools up or if it's soaking through. And certainly you would not want to wear something that's going to hold fluid, infected fluid potentially next to your mouth. I also saw someone asking about putting sanitizer or chemicals on the mask, and I would not do that, because then, you know, you're breathing all of that in, and there's no data to suggest that it's going to kill pathogens, but you're going to be inhaling chemicals.
Perfect. The next question I have for both of you is the use of eye protection outside of the clinical area. Is there any benefit? Love you. Is there any benefit to sending our family members to the stores with eye protection as well as face masks?
You know, the bigger benefit in my mind is practical hand hygiene. You know, trying to keep your hands as well sanitized as possible. So when I'm out of the store, I don't wear eye protection. I wear my, you know, typically it's a cloth mask that I wear out to the store. And anything that I'm touching with high touch, so door handles, if I'm touching a lot of, you know, things in the grocery store, if I'm handing over my bank card back and forth with the teller, if I'm touching the buttons on the pen pad, I'm thinking, okay, I've now had another contact with my hands. Let's squirt some alcohol-based hand sanitizer and rub my hands really well. And so really it's about thinking about the whole process when you're out and about, and thinking about where your hands come in contact with potentially contaminated high-touch surfaces.
Perfect. Last question for you. What precautions should healthcare workers be taking when they go home if they have sick or elderly family members?
Yeah, we've gotten this question a lot, and it's of course of concern to everyone, their own families, children, people with underlying medical conditions, or older individuals. So again, it's really the basics, and good hand hygiene, bathing or showering if you can before you leave the healthcare facility or when you get home. Can help, or changing your clothes if possible in the healthcare setting. Wearing a designated uniform can help, so that clothes can be changed and minimize the chance of taking germs home to your family. So I think those are the things, and of course monitoring yourself for symptoms, and you know, staying away from your family members and your colleagues if you have any symptoms.
My husband and I, so he's ICU and I'm emergency medicine, so we developed our own Decon routine. So we take out 2 pairs of clothes, we wear 1 pair of clothes to work, we change into the 2nd pair of clothes as we're leaving work after we've done sign out, walk straight to our car, We leave everything from work in the garage away from this little munchkin. And we like have a shower and get changed into real clothes before we give her a hug. We still end up getting COVID, but that was our home Decon routine.
I'm so sorry.
We're all better now. Any other questions from the group? Any closing remarks, Lisa and Jason, or resources that you think people could easily go to?
Yeah, I think the WHO website is a great resource. I would point folks to that resource. It's a lot of great documents. And just from a closing remark perspective, thank you all for what you're doing. We're all in this truly together around the world. And I've never felt such a wonderful sisterhood, brotherhood, family in being in the healthcare field as I have felt in this response. And, we really do, just value the connection that we can make today. So thank you for all the work that you're doing and helping everyone in your individual cities and homes.
Thank you so much, Jason.
And I would agree and add my congratulations and thanks for Nurses Week or International Nurses Day, wherever you happen to be. Our nurse colleagues are amazing, and just want to celebrate all of the work that you're doing. So thank you, everyone.
Thank you, everybody, for joining today. The website, the presentation, a resources page, and a recording will be available on the Hopkins Center for Global Health website under COVID-19 resources, and the link has already been posted. Next week, we're going to talk about monitoring and evaluating your COVID-19 response with Shruti Mehta. And we're also going to talk about the COVID-19 pandemic and its impact on marginalized populations such as refugees. And that'll be led by Chris Bryars. So thank you so much for joining. Everybody have a really great day. And Lisa and Jason, thank you so much for leading this important topic.